I'll kind of move on to discussing the recent paper I published with my colleagues. So Anna was one of our students. She's now a neurosurgery resident at Montefiore, and Peter Can was the senior author on the study. So this is, we used this database called Trinetics. So this is a multi-center, combined database essentially. It's somewhat similar to, other insurance-based registries or government-based registries, but the advantage of this is it really includes a better mix of hospitals. And so these are 75 large healthcare organizations, large hospital systems that are all contributing their de-identified patient data into the Trinetics database. And so we're really looking at huge numbers of patients, procedures, ICD-10 codes, and even medications and lab data, things that some of the other databases that have been used for large database studies like this don't necessarily have that level of granularity. So at the time that we queried the Trinetics database, we had 69 million patients in there. We were specifically looking for patients that were adult patients that had a diagnosis of IIH, that were undergoing venous sinus stenting within 3 years of diagnosis of their IIH. So we used the ICD-10 code to make sure that we had specifically those patients with IIH, and then one of these two CPT codes to indicate that they were going venous sinus stenting. And then we essentially had a bunch of rule out CPT clauses or ICD-10 codes to make sure that they didn't have, some sort of a similar diagnosis, that they were undergoing treatment for something else. Eventually, we whittled that down to 541 patients, which I think at the time that we published it, at least, was the largest kind of IIH venous sinus stenting focused study to date. And we were looking at various outcomes, both in terms of symptomatic outcomes like headache, tinnitus, vision, and then also clinical outcomes like necessity of future optic nerve sheath fenestration and shunting, and then also their medication use. Overall, the demographics tended to fit with what most typical IIH studies do, both from an age perspective. Most patients were female in our cohort, I think about 90%. And in terms of weight, there was a distribution of both patients who were obese and morbidly obese, but also patients with normal BMI. As we know, not all patients fit that typical expectation of an IIH patient. We looked at medication usage both pre and post stenting, and as well as their symptoms, and then what procedures they had in the future. So seeing that kind of all together here, I have that separated a little bit larger here. So these are the various medications that we see typically used, Diamox being the first line therapy, Topamax being commonly used for headaches, and then furosemide also to decrease CSF pressure. And we specifically between Diamox and Topamax, we saw a significant decrease in medication usage pre and post stent. So this is within the same patient. The Trinetics database is actually able to in a de-identified manner give you patient level data without being able to kind of drill down to the other details of that patient. With symptoms, we were able to see a significant decrease in every single one of these common symptoms. So headache, blindness or visual disturbance, tinnitus, and dizziness, with headache being the most common. In terms of future procedures, what we're seeing here, if you actually look at the total number of patients, so keep in mind that the denominator here is 541 patients. So out of 541, somewhere around 10 to 20 maximum number of patients getting a CSF shunt after their stent. And then same thing with optic nerve sheath fenestration. So two signs of kind of a treatment failure, if you will, for venous stenting to cure IIH. Very few patients are needing future treatment. So it's not quite as low as the 3% that was seen in the meta-analysis a couple years ago, but still overall really quite low. Very few of these patients need future procedures for their IIH. This is kind of a Kaplan-Meier curve looking at the freedom from different symptoms. So another way to kind of look at that, we can see that these are generally quite durable results. So the most durable is really going to be freedom from tinnitus. So patients that have a cure of their tinnitus within the first, immediately after the procedure or within the first month are generally going to maintain that out to 1 year, at which time we're looking at that outcome. Same thing with the dizziness, a little bit less for visual disturbances, and then the headache is the thing that kind of grows with time. But you have to keep in mind that there are other sources of headache that may be creeping in at this time. So generally, we know if patients have had an immediate benefit from the procedure, you kind of know right afterwards. They, in the pre-op or in the PACU, they're telling you that the ringing in their ears has decreased, or usually by the time you see them in post-op visit a couple of weeks later, they tell you that their headache is completely improved and they're ready to get off medication. So whatever that result is tends to hold for the most part out to a year. So the conclusions of our study, nothing groundbreaking, but at scale, in a kind of a real world study, if you will, looking at numerous centers, and this was actually a global study, even though most of the centers were in the US. We see that venous sinus stenting is alleviating headache and visual disturbance, but also dizziness and tinnitus in patients with refractory IIH. It is decreasing the use of medications after stenting, specifically for Diamox and Topamax, and patients, putting that together with our clinical experience, we concluded that patients who were failing medical management, either having refractory symptoms or unable to tolerate the side effects of the medications that they're on, should undergo imaging and evaluation for stenting if they kind of meet the criteria I talked about earlier.